My name is Dr. Fahmi Sinani. I'm a consultant neurologist in Riyadh, and today we'll be discussing assessment of the frail elderly. The outline of today's presentation is general introduction of aging with a focus on Saudi Arabia's elderly population, frailty of the elderly, the comprehensive geriatric assessment, and the efficacy and application of the GCA. And finally, we'll end with a conclusion. The learning objectives of today, and at the end of the presentation, you should be able to describe the frailty of the elderly and how to detect it, explain the concepts and tools of conducting the GCA, and develop a problem list based on the assessment of the elderly. At which age does a person become elderly, and why is aging-related issue becoming an important issue in Saudi Arabia? The definition of older age person. In Britain in 1875, anyone above the age of 50 was regarded as elderly. The United Nations mentioned that above 60 was regarded as the older population. In general, in the developing world, between ages 60 of 65 is the retirement age, and in Africa, the age is above 50. But chronological age is very different than biological age. At what age do we become old? Aging of organs and systems is very different between one person and the other, and there could be a 10 to 50 year age difference. The decline in function is very variable between 25 and 55 years, and age-related diseases usually affect those in the 60 to 65 years of age. There's an increased risk of disability in the 75 to 80 range, and an increased risk of death above 70. There is also significant heterogeneity in aging. With advancing age, it continues from maturity. There is various heterogeneity from one cell to another, one organ to another, one physiological function to another, and one individual to another. There's also significant social, cultural context from one patient, from one socioeconomic environment to another. Life expectancy is very different at birth, and you can see that the world expectancy has increased over time, and you can also see that the Arab world life expectancy has increased over time. In the Arab world, life expectancy at birth is slightly greater, and the global average has improved since the 1980s. When you look at life expectancy by gender in the Saudi Arabian population, you can see a vast improvement from the 1900s to 2010, where males and females' life expectancy has increased significantly. You can also see that the Saudi population has increased with respect to percentage of the elderly population, with it representing about 3% in the 1950s, and in 2010 about 4.1%, and that percentage is expected to increase as the Saudi population ages over time. In summary, aging is a very heterogeneous process. Age of 65 years is the most widely used to define the elderly population. With the changing age structure, proportion elderly in Saudi Arabia will increase. Thus, the problem related to aging of the Saudi population will need to be considered in planning the health policies on an urgent basis. So, discussing about frailty of the elderly, what do we mean by the frail elderly? What are the criteria of frailty? And what are the links between frailty and dependence in the elderly? We generally divide the elderly into three categories. The robust category, which represents 50 to 60% of individuals. And these are the well-controlled elderly that has diabetes and hypertension that are well-controlled. They might have a history of treated cancer, but generally they do not affect their general quality of life. The other category is the frail elderly, which constitute 30 to 40% of the population. These are the people that have decreased physiological reserve capacities, leading to impaired response to stress, at high risk of overall mortality, loss of functional autonomy, and hospitalization and admission to an institution. The last category is the dependent population, and these constitute about 10% of the population. And these are the people that have disability for activities of daily living. They're confined to their home or institution, and they're dependent and difficult to reverse. So when you look at the elderly, they have to be generally categorized into one of these three categories. And if you look at the robust category, when they have a physiological or physical stressor like a broken bone or an illness, they generally dip and they easily respond back to their normal status. Whereas the frail individual, their response will be much slower and usually not complete. And they could easily become the dependent category with their specific illness. If you look at dependence among older people, there's increased prevalence of dependence, and there's approximately 350 million in 2010, and probably 614 million by 2050. Medicine must modify and adapt to the practice in order to avoid such a dramatic scenario. And the prevention of disabilities and age-related dependency should be prioritized. When you look at the definition of medical frailty, people would have medical syndromes that could have multiple causes that are characterized by diminished strength and endurance, reduced physiological function, and that could lead to death or dependency when exposed to a specific stressor. There are specific criteria for frailty, and these could be classified into the following: unintentional weight loss of more than 4.5 kilograms in the past year, self-reported exhaustion, weakness, which is examined by grip strength, slow walking speed, and low physical activity. And if the patient has 3 or more of these criteria, they're regarded as frail. A pre-frail condition could be with the presence of 1 or 2 of these criteria. And if the patient has none of the criteria, they're regarded as not frail. When you look at the prevalence of frailty in the community-dwelling older population, the worldwide prevalence varies enormously from 4% to 59%. When you look at frailty and pre-frailty, there is increase in southern than northern Europe countries. There's also socioeconomic factors like education that contribute to differences in frailty and pre-frailty. And although there's been no studies in the Saudi population, we expect frailty to be high. In summary, there's 3 categories of elderly: the robust, the frail, and the dependent. And specific needs and characteristics need to be considered in clinical practice for each category. Frailty in a clinical situation is characterized by decreased physiological reserve capacities, leading to impaired response to stressors. With aging of the Saudi population, frailty is going to be a major challenge in the management of elderly in order to prevent disabilities and age-related dependency. Moving on to the comprehensive geriatric assessment, we will discuss what is the comprehensive geriatric assessment, what are the components of the CGA, and how do we interpret the CGA. So the CGA is a multidimensional interdisciplinary diagnostic process of the elderly. Its goal is to help physicians to identify medical and social problems, psychosocial and functional capacity, in order to implement a therapeutic project with long-term follow-up according to personal realities and the needs of the patients. The components of the CGA, other than the conventional medical evaluation, includes areas assessed systematically with validated tools. And these include socioeconomic environmental home status, functional status, mainly looking at activities of daily living, mobility and gait balance status with respect to falls, cognitive and psychological function, nutritional assessment of whether the patient is on polypharmacy and has iatrogenic side effects, and his sensory abilities, mainly looking at vision and hearing. So taking the first tool, which is the activities of daily living, a simple tool is the ADL CACS index, which is a 6-point scale looking at bathing, dressing, toileting, transferring, continence, and feeding. There are other scales to look at activities of daily living, including the Lawton Instrumental Activities of Daily Living scale, and these look at other functions such as ability to use a telephone, shopping, food preparation, housekeeping, ability to do the laundry, mode of transportation, response for own medication, and ability to handle finances. An assessment for the cognitive function of the person is best done using the mini mental status examination, which is a 30-point scale. It's very attractive because it could be administered easily and by a non-professional. It should be done in the native language of the person, and in Saudi Arabia, the mini mental status examination was translated in the Arabic language. The next assessment tool would be looking at the Geriatric Depression Scale, and there is 2 scales. One is the GDS-4 and the GDS-15. The GDS-4 has 4 questions and is scored on 4. And generally, if the score is above 0, the GDS-15 should be done. And the GDS-15 consists of 15 questions, and a score of 5 is suggestive of depression and warrants a follow-up interpretation. And a GDS-15 score of above 15 is always consistent with depression. The next assessment tool is the Nutritional Assessment Tool, or the MNA. And this looks at the patient's nutritional assessment and whether he is malnourished or at risk of malnutrition. The next scale to look at is the Balance and Gait Assessment, and a common tool that is used is the OLB score. And falls are major problems among the elderly. About 30% of community dwellers do fall each year, and a half of them do so repeatedly. Most falls do not cause death, but 5 to 10% of falls may result in serious injury. The one-leg balance score tests the patient's ability to stand on one leg for 5 seconds, and this is an easy and reliable predictor of falls and injuries. In summary, the CGA is a multidisciplinary tool that looks at both the medical, nursing, dietitian, social, neuropsychological, and physical aspects of the patient. It consists of many standardized and validated tools, and the aim of the CGA is to detect specific geriatric problems. The objective is to implement an adaptive plan in order to improve survival and function in older persons. What are the benefits and applications of the CGA? And how do we develop a geriatric problem list according to the CGA? Where is it done? And we'll give some examples of application. So the benefits of the CGA includes developing a geriatric problem list, which include the many dimensions of cognitive impairment, mood disorders, falls and imbalance, functional decline, malnutrition, polypharmacy and iatrogenic side effects, social and financial problems, and other issues like confusion or mental issues. There are specific particularities of the geriatric problems, and this does not result from a specific disease, but an accumulation of deficits and pathology in a number of different systems, which generally result in a decline in different functions. They develop when the possibilities of different compensation systems are outdated, and it's not part of the traditional disease model. Many common classic syndromes like diabetes and hypertension are associated with it, and they're often misidentified by caretakers. Who is the target population and setup for the CGA? The candidate has no specific standard criteria. They may not be efficient in advanced age or in dementia or the acutely ill patient. The typical setting could include a home geriatric assessment, acute geriatric assessment units, post-hospital discharge area, outpatient consultation, or even inpatient consultations. And specific applications can include therapeutic decisions, oncology patients, and pre- and post-surgery patients. If you look at the CGA and its ability to predict long-term follow-up, there's a meta-analysis that shows that the CGA is a very good tool to predict the long-term follow-up of decline of these patients. These are some examples of how we can use the CGA in specific treatment strategies, and this shows the European guidelines for the treatment of blood pressure in individuals where the frail patient receives different treatment from the non-frail patient. When we look at examples of CGA in the antihypertensive treatment strategy in elderly, we can see that the elderly have specific guidelines with respect to risk-benefit of treatment, their life expectancy, whether they have associated geriatric syndromes or comorbidities. And this is an example of two patients that would be treated very differently with the same blood pressure. An 87-year-old man that has uncontrolled hypertension using one drug, and a blood pressure of 165/85 that had treated prostate cancer, but his CGA shows that he has a normal mini mental status examination, normal ADLs, normal MNA, a normal 4GDS, and takes 4 drugs without difficulty and no history of falls, where the other patient is a younger 81-year-old man with uncontrolled hypertension, osteoporosis, hip fracture, but has cognitive decline, disability in his activities of daily living, is malnourished, and is taking 8 drugs and had a history of 4 falls in the last year. Which patient would you add a second antihypertensive medication for? The robust elderly patient would easily add another blood pressure medication, whereas the very frail elderly, it is not recommended to add another blood pressure medication. So in summary, with the changing age population, Saudi Arabia will have more elderly population. Frailty is a major challenge for the management of elderly in order to prevent disabilities and age-related dependency. The CGA is an important tool in the management of the frail elderly and implement geriatric care plan in order to improve outcomes of older persons. And the take-home message is that the heterogeneity of aging is significant, and we should classify the elderly into the robust, the frail, and the dependent. There are many geriatric syndromes that are not part of traditional disease model. The CGA can be used as a screen for geriatric syndromes in the vast majority of settings, and a geriatric care plan can be developed to be adaptive for individual patients, and that socioeconomic conditions must be considered in the care of the elderly. The key words from this lecture include life expectancy, elderly, frailty, geriatric syndromes, multidimensional, multidisciplinary, comprehensive geriatric assessment, activities of daily living, disability, mini mental status examination, cognitive, falls and gait disorders, nutrition, and polypharmacy.